Thank you very much for this very kind introduction and invitation to be part of the Third Oman Urological Association. I've been asked to talk about from lab to the clinic in stone research. So translational research in urolithiasis is essentially a process of converting an observation made in the laboratory, clinic, or a community into intervention that provide meaningful and applicable results. And in areas of in urolithiasis, it has impacted two major domains of management of urolithiasis. Number one is the active management, which is treatment of the stone itself. And second is to prevent recurrence, which is a major issue in urolithiasis. Well, I think we have achieved a lot in the first domain, which is active management. We have shown significantly that the open stone surgery is more for museum now, and there's hardly any indication either for urethral or for renal stones. And even the most complex kidney stones can be treated by minimally invasive surgery. We know that the kidney stone disease is a systemic disorder. Its overall prevalence in the general population is increasing, and the US data indicates that 1 in 11 person have a kidney stone. This is almost equivalent to diabetes. It has a high recurrence rate, which obviously not only have a cost implication, but also significant implication on overall health of the patient with end-stage renal disease and cardiovascular disease. The problem with the prevention and stopping recurrence of kidney stone is that we don't know for sure the etiology and pathogenic pathways in every patient. So there are areas of heterogeneity. It's important that we identify the core of centers, develop a platform for future observational interventional clinical research in urolithiasis. This is an interesting data from Giovanni Cambaro's unit and practice pattern in various European and non-European centers. You can see that although the basic blood workup is done in majority of patients, the nutritional advice, stone composition analysis is done in significant proportion. However, the 24 hours urinary parameters are not assessed in every patient, and about half of the patients have 7 out of 16 parameters assessed. So what is the indication? Should it be done on all patients? Should it be done in selected patient? In this review by Connick, Keller, and Olivier Traxler, the standard metabolic evaluation, which is medical and lifestyle history, physical examination, basic urine and blood workup, radiological examination is obviously, and a stone analysis should be performed in all patients. 24 hours urine analyses are indicated in patients who are at high risk of recurrent stone disease. In a review written by us some 5 years back, we also advocated the use of tailored metabolic workup for urolithiasis and should be done for select individuals. We lack high quality evidence, and for such common thing, which we as urologists and nephrologists and basic scientists who are involved in kidney stone management, advise to all of our patients to increase fluid intake. There is lack of good quality evidence. So this meta-analysis in the Cochrane database review, it is noted that there is no RCT on role of increased water intake for primary prevention of urinary stones. However, for secondary prevention, increased urinary output achieving a 2-liter urinary outputs are associated with decrease in the stone recurrence rate, prolonging the time to recurrence in patients who have got history of urolithiasis. This is published last year in American Journal of Kidney Disease, the proposal for the PUSH trial, which is prevention of urinary stones with hydration. And this is the design and rationale of that clinical trial published last year. As you can see, that one of the basic problem with advice related to lifestyle is the lack of or poor compliance. And in this particular trial, they have, in this study arm, have prescription fluid intake for the patient with active monitoring. And then these glasses of water are really tagged to your mobile phone. It is also in the control arm, they propose to do adaptive program behavior interventions, including financial incentives, structured problem solving, and other automated adherence interventions. Whereas in the control arm, the day-to-day advice that we do to our patients is provided about standard fluid intake. This is the complex study design, and we bid good luck to the investigators, and hopefully they will be able to provide high quality evidence that water does prevent not only for primary, but also secondary stone prevention. Pediatric urolithiasis, and there is very little controversy that pediatric stone formers should be evaluated by metabolic analysis in order to identify the cause and to treat it to prevent long-term morbidity related to. However, again, Cochrane database systematic review published a few years back show that there is lack of good quality evidence. So what the authors concluded is that oral potassium citrate supplementation may reduce recurrent calcium stone formation in children following lithotripsy. However, the author's confidence in this finding is limited, and substantial number of children could not continue the medication due to adverse events. So when should a 24 hours be ordered? And this is, again, a matter of debate among the scientists taking care of kidney stones. So should it be done in a first-time single stone former with unremarkable serum chemistry, with normal urinalysis, no family history of stones, no underlying medical condition? And the consensus is that it should only be done if the patient wants metabolic workup. However, patients with type 2 diabetes, gout, gastrointestinal conditions like intestinal resections or Crohn's disease, and all those conditions which predispose to urolithiasis, they are at high risk of recurrent stone, and they should always be evaluated by 24 hours urinary work. If you do decide to do it, what should be assessed? Well, you need to assess for what form stones, like calcium, oxalate, uric acid, phosphorus. You need to assess what prevents stones, which is citrate. And you need to also assess stone promoters, which do not become part of the stone itself. For example, sodium, as hypernatriuria leads to hypercalciuria. So pH, which is in extremes, can result in either uric acid or magnesium ammonium phosphate and calcium oxalate stones. We also need to do analysis to see potassium and creatinine, and these are basically an indicator of specimen and treatment. So if the potassium is low, it means that they have not adhered to the instructions. What are the basic blood workup? Then, well, obviously you have to do calcium. If it is high or normal high levels, then PTH should be performed, and subsequently decisions are made for about future management. Uric acid, well, 1 in 5 person with gout will form both uric acid and calcium stones, because electrolytes, if there is low potassium, low bicarb, and high chloride, and urine pH is greater than 6.5, renal tubular acidosis type 1 is suspected. Metabolic syndromes, They are not only associated with urolithiasis, they are also associated with erectile dysfunction and cardiovascular disease. So nutritional counseling, evaluation of lipid profile should be done in these patients as well. Urinalysis is the key. We know that low pH, less than 6, is associated with uric acid stones. And if the pH is greater than 7.2, they're associated with calcium phosphate and magnesium ammonium phosphate stones. Microscopy is also important because presence of bacteria, red cells, and white cells would indicate that there is a likelihood of not only mechanical irritation secondary to stone, but also urinary tract infections, and cultures be performed. Presence of crystals. Well, this is a typical cystine crystal. Their presence is indicative of cystinuria. The coffin-lid stones, crystals of magnesium ammonium phosphate stones, and the double tetrahydrons of calcium oxalate monohydrate stones. So pH and microscopy are the key which a simple urine test like urinalysis would give you and can lead you to further evaluation of these patients. Now, because kidney stone disease associated with so many other conditions, for example, recurrent calcium oxalate urolithiasis associated with osteoporosis. And it is not old age osteoporosis. It is osteoporosis seen in male patients with a mean age of 35 years and female patients of only 38 years, so premenopausal. Now, in these patients, performing DEXA scan can actually identify patients who have osteoporosis versus osteopenia and normal. So bone density with the DEXA scan is indicated. Once you have treated the stone and you have done the stone analysis, either it's a calcium-containing stone or a non-calcium-containing stone. For calcium-containing stone, you need to assess the urinary calcium excretion. And if it is normocalciuric patient, you need to look at some of the other risk factors like hyperuricosuriia, hyperoxaluria, and hypocitraturia. For patients who are hypercalciuric, serum calcium and PTH levels be performed, and these patients would then be treated accordingly. For non-calcium stones, which are usually uric acid, infection-related stones like magnesium ammonium phosphate and cystine stones, the calcium stones are monohydrate or dihydrate bevelite and wedellite. The calcium phosphate stones like carbonate apatite and brushite and hydroxyapatite are usually associated with infectious etiology. For calcium oxalate stone with normocalciuria, you need to assess excess of promoters, so specifically uric acid, particularly if the pH in these patients is 6. Consider gout, chemotherapy, and protein gluttony as the risk factors. You need to assess if they have insufficient inhibitors like citrate. An excess of solute like oxalate is important. So if it is greater than 75 milligrams per day, and there is no other cause like shortcut or malabsorption syndromes, then you are really looking at hyperoxaluria and that this patient requires further intense evaluation. However, if it is less than 75 milligrams, then increase oxalate and low calcium intake. And I remember our co-chair, Dr. Robertson, once telling us over a dinner table that have your tea with milk to neutralize oxalate. So patients with calcium stones, with hypercalciuria, well, you need to do serum calcium if it is on the high side, PTH levels, And if the PTH are increased, obviously, the next step is parathyroidectomy. If the PTH low, then sarcoidosis is something that needs to be entertained. For patients with calcium phosphate stones, calcium apatite, and brushites, hypercalciuria, hypocitraturia, and various conditions which can result in metabolic acidosis needs to be excluded. So what about pharmaceutical treatment? Well, if you have normocalciuria and you have hyperuricosiuria, allopurinol is recommended. If you have normal calciuria with hypocitraturia, potassium citrate supplementation, normal calciuria with hyperoxaluria. So normal calcium, low oxalate diet, calcium citrate, and for enteric hyperoxaluria and B6 are all helpful in that situation. So patients with hypercalciuria, with increased calcium and increased PTH, surgery or cinacalate is recommended. Hypercalciuria with normal calcium, again, thiazide and potassium citrate. So there are very few selected medication that needs to be given. So even for surgeon, it is not very difficult to remember those 7 to 8 medications that needs to be recommended in these patients. For non-calcium stones, the mantra is no acid, no stones. So alkalinization of urine, and the goal is to achieve serum, the pH up to 6.5. So when the pH increases from 5 to 7, the solubility of uric acid increases 20-fold. So it's important that the urinary pH is monitored regularly to see the efficacy of treatment. Low purine diet and high fluid intake are obviously recommended. For infectious stone, well, no bacteria and no stone is the mantra. So it's important that no residual stones are left. Antibiotic regimen for 2 to 3 weeks, and preventive doses of antibiotics can be given up to 3 months. Acetohydroxamic acid, which can be given up to 750 to 1.5 grams, basically blocks the urease enzyme, which is responsible for the formation of magnesium ammonium phosphate stone. For cysteine stone, you really need to increase the urinary output to 3 liters. Low sodium diet, potassium citrate to alkalinize the urine, keeping it above 7, and decrease the urinary concentration of cysteine to less than 250 milligrams. Well, Sir William Osler said that one of the first duties of the physician is to educate the masses, not to take the medicine. So this is something that you can tell all your patients, that increase urine output from up to 2.5 liters per day, intake of 3 to 4 liters, depending upon your level of exposure to high temperatures. At least in my country, people believe that they can take 4 glasses of water in the morning and nothing for the next 6 hours, and then maybe another 2 or 3 glasses later in the day. What is recommended is circadian drinking, a glass of water every hour while you're awake. Low sodium diet and low animal protein diet, all is helpful. And this is something that very clearly recommended by the European Association guidelines. Another misconception among the general population is that they need to decrease their calcium intake because they had a calcium oxalate or calcium phosphate stone. That's not true. So in a recent paper looking at the perception of various risk factors, we noted that this is one of the things that people like to reduce their milk intake or calcium intake. It is recommended that you should be taking 1 to 1.2 grams of calcium per day, and they're important to chelate oxalate in the gut. So lab to clinic, Well, the observation is that phosphoric acid in carbonated drinks has an impact on the crystallization of screw whites. So if we take these observations to the clinic, residual stone, you use carbonated drinks which contains phosphoric acid with Proteus mirabilis infection, and this recipe is disaster. You will be forming screw white stones. In a paper published a few years back in British Journal of Urology, they've looked at the use of plum juice in reducing the chances of screw white stones. Another important area is the residual stone, and most of us and patients believe that residual stone become the nidus for stone formation, and they're not very wrong in that perception. This is a randomized controlled trial published in New England Journal of Medicine last month. They've looked removal of small asymptomatic kidney stones and looked at the impact of removal of those stones on relapse. So they noted a 5-time decrease in the relapse of stones if you have removed small stones at the time of doing surgery for the major stone. So this would increase the time to another 25 minutes in that particular trial. And the authors concluded that secondary small stones removal at the time of primary stone removal significantly decreases the chances of relapse without increasing surgery-related complications. Majority of your patients present with calcium oxalate stones. They have metabolic abnormalities that are not present, or they have been appropriately addressed. Or sometimes they don't have any knowledge of their metabolic background. So in those patients, empiric thiazide diuretics and potassium citrate should be considered. And these therapies have shown to decrease the recurrence in stones. It's an interesting paper by Clayman, Patel, and Margaret Pearl, and they have provided that stone tree. So the authors noted that in a compliant patient, the remission rate can be up to 90%. In total, the urologists need to understand that there are only 8 potential diagnoses. You need to familiarize your patient with fluid and diet, 8 pharmaceutical regimen to remember, and with these, they will be able to decrease the chance. So in summary, it's still controversy about whether metabolic evaluation be done in one or in few. What should be the follow-up strategy and how frequently you need to see this patient? Who should be following these patients? A urologist who has treated the stones by intervention, by urologist with special interest in stone prevention, a nephrologist, nutritionologist, etc. We are marred by high-quality evidence and lack of longitudinal studies. However, there are certain measures which are well established now, although we still have a lack of high-quality evidence. But fluid intake, identifying basic metabolic disorders, and treating them with the strategies that have been discussed in this presentation are key to long-term prevention of urolithiasis in your patient. Thank you very much for your time.